He is a retired HOD, Department of General Medicine, Madurai Medical College. At present, he is a senior consultant of Heart Failure Clinic at MMHRC, Madurai. Next chairperson is Dr. Purushothaman. He completed his MBBS from Madurai Medical College and MD General Medicine from Madurai Medical College. He is now he is a retired HOD of Department General Medicine in Theni Medical College. He is a senior consultant now in MMHRC, Madurai. Dr. Sindhu, she completed her MBBS in Coimbatore Medical College, DNB Family Medicine from KG Hospital, Coimbatore, worked as intensivist at KG Hospital. Now she is HOD, Department of Family Medicine at KG Hospital.
There are two speakers for this session, Dr. Narendran and Dr. Sampath Kumar sir. First speaker will be Dr. Narendran. He has finished his MBBS at the year 2011 from Government Kumaramangalam Medical College, Salem, and then did his DNB General Medicine in the year 2016 from Meenakshi Mission Hospital and Research Center, Madurai. He then worked as a registrar in the Department of Neurology in Meenakshi Mission and then did his DM Neurology from the renowned Institute of NIMHANS, Bangalore, and is currently working as a consultant in the Department of Neurology in Meenakshi Mission Hospital Research Center, Madurai. He has presented a thesis on genetic correlates of hereditary spastic paraplegia, one of the rare neurological conditions, with one of the largest cohorts from India. Over to the chairpersons.
I welcome you all to this session of great importance. We have two speakers. Both will be talking on the golden hour. The golden hour is gaining more importance in other specialties also, including in trauma and other poisoning cases, many road traffic accidents. Everywhere golden hour is given more of importance. The first 30 minutes and 60 minutes after a stroke is very important for salvage of brain tissue. So that the idiom is time is brain. I request the co-chairperson to.
Good afternoon, everybody. As per the perspective of family medicine, this is very important because the patient comes to us first. And then you have to diagnose what he has and refer him aptly if you don't have the facilities to treat him. But basically, you must understand this golden hour because you may be able to save him to some time, whether it is neurology or the ACS, where the loading dose of the drug may be useful to the patient. Also, you must know that this time is very important because thrombolytic therapy in ACS or stroke, especially in stroke, 3 hours is very important. It has been extended even up to 24 hours. Now, the latest guidelines, if you are planning some mechanical thrombectomy or you have a vertebral disease and all that. So, things are moving so fast, you should be updated on both this neurology and cardiological emergencies like ACS and stroke because easily preventable. Diagnosis of TIA is very, very important in the setup. If you miss a TIA, he may come back to you with a full-blown stroke. So, prevention is better than cure. So, I think this is very important for our practice. So, over to sir.
As already told by our chairpersons, these are the two conditions. There is acute condition stroke. Both are very important scenario. By giving this golden hour treatment, we can decrease the incidence of death. ACS death incidence is 48% approximately. Stroke incidence of death is 17%. This can be reduced substantially. So it is very important. This is very important for PGs as well as our family medicine faculties. Thank you.
Now they are talking about platinum 10 minutes. Golden hour is reduced to platinum 10 minutes. Over to Narendran.
Good afternoon, everyone. I thank the organizers for giving me this opportunity, and I'm very honored to be presenting in front of my teachers. So, my topic is on golden hour and stroke. I thank the organizers for prioritizing brain over the heart. because they called me first to present. Because at least for heart, there is some kind of there is some awareness about acute cardiac, acute ischemic myocardial infarction. Because the most important point which brings the patient to the hospital is pain. Patient who has pain, they come to the hospital very fast. But when it comes to stroke, there is no pain. There are people who lose their ability to use their hand, but they don't worry about it. They come after 3 days, 4 days. So that is the awareness in the public sector. And there are very non-specific symptoms which start early that patients are not very aware of. When they have hemiparesis, when they have facial drooping, when they have any slurring of speech, they think that something is wrong. But they don't know that something is wrong when they lose their vision suddenly, or when they have a sudden onset altered sensorium, or when they have imbalance. So they think, they attribute it to many other reasons. They think that it is due to hypertension, they think that it is due to poor food intake, and they come to the hospital late. So the first referral point the patient reaches is the primary care physicians. And can anyone tell me what do you do when you see a patient with acute stroke in a window period? Anyone? Huh? Send to MRI scan. Where? What? I'm not able to hear. Loud, please. NH is scoring. No, you should refer the patient. That is the first point. You should refer to the patient to a center which has the management for thrombolysis and thrombectomy. I'm saying in general, because once it changes to, out of the window, then there is no issue. But once the patient comes to you in the window period, if you don't have the facility for a CT imaging or the acute stroke management team, I think it is better to refer the patient. And I always ask primary care physicians not to start heparin or antiplatelets if the patient is in window period. Because if you give 1 dose of heparin, the risk of bleeding from thrombolysis will be more. So when you see a patient in acute window period, then it is better to refer the patient as fast as possible to a center where the stroke facility is available. So going into the topic. So why we call time is brain, we'll come to know in the coming slides. Because as each time passes, each minute passes, the number of neurons which get destroyed is exponentially increasing. Not slowly increasing, it is exponentially increasing. There are many studies which show that the faster the door to needle time, the recovery is good. And as the sir told, it is not just about the rapid reversal of deficit, which happens very rarely. The main aim for thrombolysis is to look for 30-day mortality or morbidity. Patients who receive thrombolysis, they do well after 30 days or 90 days. They return to work very soon. They have a minimal disability and they can take care of their own life as early as possible. So that is why it's called as time is brain. So you have to act fast. That fast is actually an acronym. That is, it shows facial drooping, arm droop, and then speech slurring, and time. This has to be very fast. A patient has to come as soon as possible to a center. So as I told, a deadly yet understated emergency. The understanding is very less. That is a main lacunae in acute stroke management. I can see that I mean the understanding is better nowadays. We are seeing more and more patients who come in the window period where we can thrombolize. The number of thrombolysis has gone up, but still there are many deficit. So stroke is the second most common killer amongst all non-communicable diseases in India. That is, it is around 15.4 lakh people, and 6.3 lakh deaths can occur because of stroke. And 41% of the patients do not survive from stroke. And you have to consider about the post-stroke morbidity and the lack of income. The earlier you treat, the greater the benefit. Can anyone tell me what is the abbreviation NNT? What is number needed to treat? Huh? Number needed to treat. Should be high or low? Low. What does it mean actually? It says that less than 90 minutes NNT is 4 to 5. But at 9 minutes to 3 hours it is 9. Whereas from 3 to 4.5 hours NNT is 14. What does it mean actually? Yeah, that is, we need to treat 4 people to benefit 1. So the number of people you need to treat to benefit a single person is 4 to 5 when you thrombolize within 90 minutes. The number needed to treat increases. So the number needed to treat should be low. That is the meaning of the abbreviation NNT. There are different types of stroke, and ischemic stroke is the most common thing, and the other thing is hemorrhagic stroke. There are many other causes for stroke like cardioembolism and small vessel lacunar infarcts, but we'll have to understand the fact that 30% of the strokes are cryptogenic. That is, even after extensive evaluation, you will not find the cause for stroke. So pathophysiology is, it is a result of vascular occlusion to a part of a brain. Major blood vessels are anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. So any blood vessel blockage in these arteries can cause ischemic stroke, and the symptoms are pertaining to the area affected. So that is why the symptom of this stroke can vary. There are patients who present with very sudden onset altered sensorium. So I generally tell any sudden onset abnormality pertaining to neurology, always consider vascular and stroke, because acute is different. When sudden, it is almost always vascular. So region of ischemia, you all know that there is ischemic core, umbra, penumbra, all those things are there. It all means that the infarct zone gradually increases as time passes. So the penumbra is the area where the tissues are still salvageable. So how to spot a stroke? As I said, face drooping, arm weakness, that is pronator drift, and difficulty to talk. And then you have to understand the time matters. You can add more, 2 more letters. B first. B can be balance, E can be eye symptoms. So I thought I'll cite some cases. It's a patient number 1 is a 65-year-old male, 3 episodes of transient weakness of left upper limb and lower limb, presented to us during the episode well within the window period. Virally localized, the patient has nothing else other than left upper limb and lower limb weakness. So where can you localize? Okay, I'll change the question. Where all can you localize? Right? That is lateralization. Okay. Neurology, there are 2 things: lateralization and localization. Lateralization, you are telling the side. Localization, you have to tell the anatomy. So lateralization is, as you said, right side. So which arteries can cause left upper limb and lower limb weakness? MCA. That's all. Then there is no other associated symptom. You see this patient, where will you localize? Because you have to know where to look in the imaging. That's why. It can be anywhere. It can be in the brainstem also. It can be in the ACA also. So that is the issue. But we can tell if the lower limb is more, then it can be ACA. But otherwise, this is pretty non-localizing. So this is the images done immediately after the patient came. What is the first sequence? Can you tell? First image on the to my right. Okay, right hand side. that in. What is that image? CT angiogram, that is CT contrast. So you can see that left, because the case, I know the case, I'm just putting the important slides. So you can see that the left middle cerebral artery is well patent. This is the middle cerebral artery, you can see it is good. Okay. So what is this image? Anyone else? This is flare image. You can see it is looking like T2, but the CS of spaces are all dark. That is, the fluid is inverted. So that is a flare image. This is a DWI. What other sequence we'll have to see along with diffusion? We have to see other cuts like apparent diffusion coefficient, that is ADC images. Only that will tell whether it is a cytotoxic edema or vasogenic edema. So as I said, this is flare, this is DWI, right? It is changed. Okay. So the patient came in the window period, he received IV thrombolysis and he was started on antiplatelets after 24 hours. Continued, but he continues to have multiple episodes of TAA in front of us. He continued to have around 10 to 15 episodes of TAA every 5 to 10 minutes he's getting. So we started him on heparin, episodes stopped. We did a repeat CT. You can see that the repeat CT is normal. There is no infarct. So we thought it is a multiple TAAs. So he was on heparin, he was in the ICU, then he shifted to ward, and then in ward he was about to get discharged. The previous day he starts having episodes. So again the same left upper limb or lower limb weakness lasting for 5 minutes, then again it is becoming normal. He has no slurring of speech, he has no other deficits. And second episode on the fourth day terminates in a full-blown weakness. It is not recovering. So we did a repeat imaging. What do you see? You see an infarct in the capsuloganglionic region and in the coronary data, here and here. Okay. So you should see that the infarct looks little different ages. This one looks new, this one looks a little bit old. 4 days back we did an imaging, it was normal, but within 4 days we have 2 different infarcts. So what do you think is the diagnosis? This is actually a classical case of capsular warning syndrome. So you can see that it is just a lacunar syndrome. The infarcts can occur in any area. It can be in the internal capsule, it can be in the pons, it can be in the striatum, thalamus or midbrain. So capsular warning syndrome, actually patients have very dramatic presentation, multiple episodes of TAA, usually none of the treatment works, and the patient gets relieved only when the weakness becomes permanent. So that kind of alarming symptoms it can present with. It is said to be because of the hemodynamic instability in the lenticulostriate branches. So they have found that none of the treatment is very helpful. Even thrombolysis does not help the patient. It ultimately ends up in infarct. They say that the infarct has already happened and is not picked even by MRI. That's why there is 2 different ages of infarct in the 2 different CTs. So this is a classical case where even if the patient comes in window period where you can't do anything. So as I said, there are 3 stages of stroke. Stage 1, it's a pre-hospital phase, then it is a hospital phase, and then it is the post-rehabilitation center. So pre-hospital phase is a very important phase which you are all concerned. It should be treated as an emergency. As fast as possible, the patient should be shifted to a higher center where there is facilities for thrombolysis or endovascular treatment. Stage 2, when the patient comes to hospital phase, there should be proper coordination between neurology team and the emergency team and the radiology team. All the other emergencies, emergency scans should be stopped, and then this should be the immediate response that patient should receive CT brain to rule out hemorrhage. Then you have to do a CT angio to look for any large vessel occlusion. Because the management changes, large vessel occlusion, you go for mechanical thrombectomy. If there is no major large vessel occlusion and you see CT is normal, you have to start treatment. You should not wait for CT angio also. You should start thrombolysis on the bed. Then after doing CT angio, if there is no larger occlusion, you can continue the thrombolysis, and then next you have to manage the patient for the next 24 hours to look for bleeding or to look for any hemodynamic instability. Then after stage 3, you have to go for proper rehabilitation. So as I said, stroke channel survival depends upon all this area. Patient, he or she should come as early as possible when the symptoms occur. Then the emergency team. Nowadays there are portable CT machines inside an ambulance where they do a CT and then thrombolyze. The door to needle time in countries like Canada is just 15 to 20 minutes, and it is considered as a standard of care where you don't need the patient's consent to thrombolyze or remove the clot. Then the transport, then the CT MRI, and then the treatment. So when the patient comes to emergency, you have to look for airway breathing circulation, you correct hypoglycemia, you correct hypertension, and then if a patient has any fever, you give paracetamol, and then there is no absolute contraindication as of now except intracranial hemorrhage or recent head trauma. We can start thrombolysis. If the patient is on oral anticoagulants, then we have to wait for PT-INR. If it is more than 1.5, you cannot thrombolyze. If it is less than 1.5, you can thrombolyze. So key components of history, you have to ask for onset of symptoms. The important point you should ask is last seen normal. That is the important question you have to ask the patient's family. When did you see the patient normally last? Because usually this is vascular, the patient's family will be able to tell the time. He was good walking away at 7 o'clock, and then he came back from walking, and then he started having symptoms. That is a usual history patients tell. The exclusion is wake-up stroke, where they see the patient well the previous night. Then you have to ask for recent events like head trauma or any surgery. Then you ask for bleeding tendencies, comorbid diseases like hypertension, diabetes, and then use of medications if there are any anticoagulations, and then you have to check for PT-INR. So as someone said, NIHS scale, for thrombolysis, NIHS scale is nowadays not very indicated, but it is useful to look for improvement. 24 hours later, if the patient has improvement of 40% from baseline NIHS scale, it means the patient will have a good outcome. So NIHS is out of this topic, but you can see that there are 11 points, and you have to see, basically you have to see whether the patient has any signs of large vessel occlusion or cortical signs like hemianopia or hemi-neglect or hemi-anesthesia. If you see any of this cortical sign, you have to think of a large vessel occlusion. If it is only weakness, most probably the patient has a capsuloganglionic infarct. That is the same NIHS scale. This is a card used to check for hemianesthesia, hemianopia, and hemi-neglect. And then for reading, they can read language, everything can be checked. But this is westernized. Indian, you can ask for routine in your vernacular language, you can ask. So coming to imaging, early CT signs of cerebral ischemia, you can see, what do you see here? When you compare to the left side, right side has a hypodensity. This is a little later stages where you can actually pick up. Sometimes only a radiologist can pick up very minute signs of acute stroke. What do you see here? What is the loss of insular ribbon here? That is one more point. The effacement of cortical sulci and gyri. And here, if you see around, this is the insula. If you see, there is a ribbon-like hyperdense area around the insular cortex. But if you see there, the ribboning is not there on the right side. So that is what is called as loss of insular ribbon. Then you can see the hyperdense middle cerebral artery. It means there is a fresh thrombus there. One more point is aspect score. I think people would have heard it. This is very important in mechanical thrombectomy, where you divide brain areas into 10 based on the studies conducted in Alberta stroke program. You can see that the caudate, lentiform, the thalamus, internal capsule, M1, M2, M3, M4, M5, M6. These are the 10 areas. You knock out each point for the areas involved. You have to keep the CT machine at a particular window setting and then look for subtle signs of involvement. If the aspect score is more than 6, it means the infarct is not yet big, and then you can go for mechanical thrombectomy and patient will have good outcome. If the aspect score is less than 6, that is more areas are involved, then the outcome is poor. So again, as I said here you can appreciate the insular ribbon here very well. This insular ribbon is very clear, but here it is lost. So that is the anterior insula, this is the posterior insula. This is the insular ribbon which is very, very clear here, but you don't see that ribbon here. This is the loss of sulci gyri as Sir pointed out. You can see the sulci gyri very well here, but here this effacement is there. This is the later image that shows that the infarct has progressed in this area. It has established the same after 2-3 days. These are all various images, similar images, where you can see the loss of caudate nuclei. This is how we do aspects. You see the caudate hyperdensity here, but you don't see it here. That means the caudate is involved. And the same way, you can see that the internal capsule is also involved here. So these are the various subtle signs which will tell you that there is stroke going on. There is similar aspects in the posterior circulation. You have to think of occipital lobe as one area, thalamus, midbrain, bilateral midbrain, bilateral pons, and cerebellum. As I say, time is brain. Any untreated patient loses approximately 1.9 billion neurons, so you have to act fast. Coming to case 2, is a 62-year-old male, wake up stroke, right hemiparesis, and has aphasia. He was last seen normal 11 p.m. previous night. So this is the classical wake up stroke. What do you do now? No, we have to. There is various trials which shows that extended thrombolysis or thrombectomy can be done. We have to look for diffusion flare mismatch or perfusion diffusion mismatch. So perfusion is not very easily available, but you can see this is the DWI, this is the ADC. You can see this is cytotoxic edema because of the infarct, but you see the flare, there is no infarct here. The previous slides also would have had infarcts, but I chose this picture. So he went under IV thrombolysis because the infarct is not yet established. This is the NIHS improved around 20% after 24 hours, and the CT brain after 1 week, you see that the infarct is established, but the patient did not go in for midline shift or did not require any surgery, and the outcome of the patient at 30 days will be better when compared to patients who have not received thrombolysis. That is the mainstay of thrombolysis currently. So treat stroke as an emergency, and at every stage it should be fast. So only 2 to 12% receive thrombolysis, and delayed arrival is the main reason, and sometimes drug is not available or in-hospital delays are common. This is the drug study showing altiplase is better when compared to control. And RTP effects are time dependent. Only 11% of all thrombolyzed acute ischemic stroke patients receive within 90 minutes, which is the golden hour, very, very less, even more less in developing nations. But if you see as the time goes, the outcome will be poor. These are the various indications and contraindications, but nowadays it is very much reduced, unless until patient has hypertensive bleed or intracranial tumor or patients with coagulopathy or recent MI and recent stroke, patient cannot receive thrombolysis. But otherwise, all the patients who present within golden period, window period, or patients who are select patients who show diffusion perfusion mismatch can be taken up for thrombolysis. So, as I said, faster door to needle time, the NHS improvement is better, and the faster door to needle time will give more improvement if the involvement is in the territory, because the deficits will be more and then the improvement will be graded more. Whereas if the infarct is in the capsoganglionic region, patient will only have hemiparesis, so the difference may not be very clear, but the outcome at 30 days or 90 days will be better. So shorter time to thrombolysis, patient will have better prognosis. This is patients who entered outside the therapeutic window, did not receive thrombolytic therapy, had walking disorder 2 times more common than patients who received in the first hour of stroke. As I said, predictors of early neurological development, I said that within 24 hours, if the NIHS improves from 40%, or the patient has a mild baseline NIHS score, or higher aspect score, the outcome will be better. Coming to the next point, mechanical thrombectomy, these indications are very limited. Only when patient who has presented in a window period or as a division-perfusion mismatch with the large vessel occlusion, that is stem of MCA or possibly M1 segment, can undergo thrombectomy. As I said, aspect score should be more than 6. You see the number you need to treat here, 2.6. That is, you need to treat only 3 patients to benefit 1 patient. Coming to the case 3, 60-year-old male with type 2 diabetes and hypertension, sudden onset altered sensorium. As I said, this is one of the stroke presentation. 7 hours from symptom onset. He is outside the stroke window. This is the CT imaging. You can see what is the abnormality here. Can you see anything? Abnormality? You can see this is the left vertebral artery. You can see a hypodensity within the lumen. That is the thrombus, fresh thrombus. You go behind, you can see the thrombus is extending here. And it goes up to the basilar artery, formation of basilar artery. So it is in a very tricky area, which is in the V4 segment. It is in a bend. So usually thrombectomies can be very difficult. This is the patient's MRI. You can see this is the diffusion. You can see the entire occipital lobe is involved. And if another slides will show that the temporal lobe is also involved here. You can see when compared to the right side, left side, there is a little hyper intensity on the gyral area. That is gyral edema, which shows early infarct. The patient has presented well outside the time window, but you see that there is definitely mismatch is there. And more important point, the brainstem is not involved. That is a more important point in post-circulation stroke. We'll always have to consider the brainstem. Even if the patient presents within the window period, the brainstem is already infarcted, there is no point in doing any intervention. So patient was taken up for thrombectomy after explaining the grave prognosis because they came after the window period. But we did thrombectomy because there was a flare mismatch and brainstem was intact. This is the next day. Unfortunately, the patient has developed bilateral thalamic infarct and bilateral occipital lobe infarct. The possible reasons: delay in presentation, in-hospital delays, transition delays, difficult anatomy and the location of thrombus, possible re-occlusion. There is 30% chance of re-occlusion in a patient who undergoes mechanical thrombectomy. That is always a possibility. And then importance of stroke audit. We'll have to form a stroke team and we have to discuss the reasons why there was a delay in taking the patient from the emergency room to the CT room or to start the thrombolysis. So that is very important. So candidate for endovascular therapy, age more than 18 years, NHS score more than 6, time from onset to groin puncture should be less than 6 hours, up to 24 hours if the evidence is of sizable penumbra is there, that is diffusion flare mismatch is there. Good pre-stroke functional status. A patient with bed-bound Parkinsonism develops a stroke, there is no point in doing thrombectomy or thrombolysis because the patient, even if the patient survives from stroke, will not be able to walk because of the Parkinsonism. So we'll always have to consider the pre-stroke morbidity or the functional status. MRS score is there, patient is functioning, walking, independent, then you do the thrombectomy or thrombolysis. But patient is already bed-bound, there is no point in doing these procedures. Alberta stroke program aspect score should be more than 6. That is less than 3 or 4 areas should be involved in the CT. And the most important point, presence of proximal intracranial artery occlusion. Note the point, intracranial artery, not the extracranial artery. Intracranial artery is MCA or basilar artery. Basilar artery also, if the patient presents within 24 hours also, if the brainstem is not involved, patient should undergo thrombectomy because the outcome will be drastic. This is an example from internet. You can see in the digital subtraction angiography, the MCA is cut off here. This is the ACA. This MCA is cut off here. After the procedure, you can see the nicely filling MCA. That is the importance of mechanical thrombectomy. But even if you open the vessel, the patient infarct should not have developed. If the patient has already developed infarct and then you open the vessel, there is no point. So that is why timing is very important. As there is a TIMI scoring in myocardial infarction, there is something called a sticky scoring in stroke, where TICI 0 is there is no reperfusion, TICI 3 is full perfusion with filling of distal branches. The adequate therapy should be 2B or 3. That is perfusion with more than 50% of distal branching at least. That should be the target. These are some slides about stroke mimics and chameleons. Stroke mimic is, it looks like a stroke, but it is not a stroke. Stroke chameleon is, it looks like something else, but it is actually a stroke. We need to be very aware of stroke chameleons, actually. So mimics account for 20 to 25% of suspected stroke presentations, depending on the context. Unfortunately, brain imaging is not a simple answer. Clinical scenario is very important. The reference standard of diagnosis can only be clinical history and examination and supported by brain imaging. Entire neurology, there is no substitute for clinical examination. No length of investigations can help you in treating the patient. The important point is clinical. These are the various stroke mimics. Most important is seizure, then is syncope, sepsis, dementia, metabolic causes, hypoglycemia. They are all very great stroke mimickers. How to differentiate between each? You can see that seizure, there will be focal deficits secondary to seizure like Todd's paralysis, but you'll always have to ask for the actual seizure episode. Then hypoglycemia, patients with hypoglycemia can present with aphasia. That is very important. Just because patient is having aphasia does not mean he is having stroke. Stroke chameleons, this doesn't look like a stroke, but actually it is a stroke. One most important example is vertigo. Next is monoplegia. If there is AC occlusion, where there is a very small strategic infarct in the parasagittal area, only lower limb will be involved. You will be thinking it is a case of lumbar sacral plexitis and sometimes delirium. Sometimes patients may present with cortical wrist drop or cortical foot drop. Those two are very important. It either is a stroke or a peripheral nerve palsy. TAA mimics can be migraine aura, seizure and syncope, and TAA chameleons can be limb shaking TAAs. Limb shaking TAAs, multiple, some people will have movements during TAAs which will be falsely taken as strokes, seizure. And as I said, capsular warning syndrome, again, this is actually a stroke, but it will be mimicking like a seizure. Thank you.
Dr. Narendran, can you tell them what's the importance of cerebral perfusion pressure? Because that's very important for them. How do they maintain? They should understand what that is. Because if a patient comes with BP of 160/90, they may misunderstand it and think we have to bring down the BP because the patient has a stroke. So please tell them about CPP.
Always don't meddle with cerebral autoregulation because brain, any patient, if you ask with patient with stroke, they will say we found out he has hypertension just at the time of stroke. But it may be reactionary or it may be due to autoregulation. We do not know actually if the patient has hypertension. There are many other ways to think, like concentric LVH, which will help in saying that the patient has a chronic hypertension. So the recommendations for acute stroke management, never bring down the BP below 190 or 180. And it should not be above 210. So if it is above 210, you have to bring down the BP to 190, not below 190 or 180, not below that, because it can cause reperfusion, injury or hemorrhage. So never bring the BP down very rapidly. If you think the patient has mild stroke-like symptoms and he has hypertension, think before reducing the BP, because he might be having a TAA.
Narendran, what is the incidence of monoplegia and how will you manage? Monoplegia.
No, monoplegia, it's very rare in the lower limbs actually. We don't see ACA territory infarcts as I showed with lower limb weakness alone. But cortical wrist drop, that is upper limb wrist drops are very common. We have seen many patients being treated as radial nerve Saturday night palsy, but actually the patient will have wrist drop because of a small stroke. How will you differentiate cortical wrist drop from radial wrist drop? You have to check for the muscles. Radial wrist drop, patients will have only radial muscle weak, radial muscle supplied by radial nerve. But in cortical wrist drop, you can see the muscles involving the muscles supplying the median nerve and ulnar nerve and also radial nerve will be involved. Patient cannot make this symbol with a wrist drop. Always think of stroke because this is by median nerve and sometimes ulnar nerve muscles also will be involved. A patient with multiple nerves presenting very suddenly is very rare. So always think of cortical foot wrist drop when there is multiple muscles involved. So always check for a patient who has wrist drop. Most of the people will present with wrist drop on Sunday. So it does not mean that the patient has Saturday night palsy. You have to think of stroke also and then simple maneuver. You can ask the patient to do like this. If there is weakness of this muscle, this action, you always have to think of stroke. Same way there is foot drop also. Multiple nerves are involved. It is very rare for a mononeuritis multiplex to present suddenly. So that is why you always check for multiple dermatomal plus myotomal weaknesses.
Questions from audience? Questions, please.
Nowadays we don't use nifedipine. The best safer way is labetalol because we don't want nifedipine can act longer. So we don't know how good control will come or sometimes it will go for more hypotension. So it is better to use a short acting drug like labetalol to bring the BP down. I'm not sure. Is it contraindicated? I don't know. I'm not sure. In pregnancy, it can be used. I think it's not contraindicated. It's safe.
PIH. It can be used.
No, that's why if BP is above 201, 210 only, you should reduce. Otherwise, it's not advised to reduce the BP. Even if it's 200, 210, it's okay. If it goes to 230, 240, we rarely see the patients. If the patient has a BP of 240, 230, it is mostly bleed. It is not actually stroke. Usually strokes will have around 210, 200. That will be the autoregulation.
And one more request, sir. So we'll be placed in emergency where in OP setup where specialties will have CT or MR angiogram and all. And these people without the report, they'll come to us with the what do you call this film alone, and they'll ask for the report. So we'll be really in a pathetic situation. We can't commit anything. Like CT, brain and all, except infarct and hemorrhage, nothing we knew. So we'll just convince them everything seems to be okay, but we'll wait for the report and tell you definitely. So it will be better if you give us a crisp thing on or 5 minutes regarding infarct or hemorrhage, CT images, like MR angiogram or.
I don't have the images, but CT, you want to diagnose. No, that's why I'm telling you. Clinical is important. Even I showed one case, no.
Yes.
That case, we did MRI, we did CT, we did angiography. It did not show stroke.
No,
The clinic,
to be frank, I do not know much on CT images and MR angiogram and all. Except these two, without a report, I cannot diagnose. Any CT, abdomen and all, Suttama, I don't know.
Okay.
So
We have
Radiology is difficult. Neuroradiology is a difficult part of radiology that I think any radiologist will accept because the radiological images will have multiple DDs and the diagnosis is purely clinical and it has to be done with the discussion between radiologist and radiologist and neurologist. So radiology is difficult. So if you suspect stroke, it is better to think it is stroke and then manage as such. Okay. So if CT is showing because films, no, they don't give you in the proper window. There is a window setting where we have to adjust to see acute stroke changes. Like as I said, loss of insular ribbon or loss of hyperdense in thalamus or basal ganglia. All these things has to be set in a window of 20 to 20. So that they won't print you and give. So that is very difficult. Unless you see in a console, it is very difficult to say the stroke is there or not. But most of the times, patient with stroke, within 24 hours, CT will not show anything.
Okay.
But in MRI, it will definitely show. All you have to look for is ADC mapping and DWI. Those two will be there. They would have named it at least. So DWI will be showing hyperintense regions. The corresponding area should be hypointense in ADC. That is the only indication of an acute cytotoxic edema. So if it is both hyper, it is vasogenic edema, it could be anything. So acute infarct, it should be hyper in DWI and hypo in ADC. That is the only way you can tell it is a stroke when the patient presents to you within 24 hours. There is no other way radiology is going to help you. It is going to be only clinical.
Thank you.
Further discussions can be had personally with the speaker. We will go on to the next topic.
Thank you.
Next topic is golden hour in acute coronary syndromes. Timely management of acute coronary syndrome can reverse the effects of occlusion, and most deaths in cardiac arrest occur during first hour, and there is a lot of window of opportunity for the cardiologist to intervene and salvage myocardium. Over to Sampath.
Dr. Sampath Kumar. He completed MBBS from Madurai Medical College, Madurai. He then finished his MD General Medicine from JIPMED, Pondicherry. He did his DM Cardiology at Sri Jayadeva Institute of Cardiology, Bangalore. He has worked as an independent consultant cardiologist at Apollo Hospitals, Usha Mullapudi Cardiac Center, Hyderabad, and BGS Global Hospital, Bangalore. He is currently working as a senior consultant cardiologist at Meenakshi Mission Hospital and Research Center, Madurai. He has presented various papers in international conferences and has been awarded the best paper for the Dr. Malaka Reddy Award for Preventive Cardiology.
Thank you. I am Dr. Sampath, and I thank you again for giving me this talk after the neurology talk, at the end of the session. Because at the end, you will listen to the heart only. You won't listen to the brain, okay? You will listen to the heart only. Listen to the heart, okay? And my talk is about golden hour in ACS. See, when there is an opportunity to get a piece of a gold, what will you do? You will rush and get it as fast as possible. So the answer for this golden hour in ACS is as early as possible. You rush and do it things fast. So ACS is a spectrum of acute ischemia related syndrome ranging from unstable angina to myocardial infarction, which is due to a secondary to a plaque rupture or a plaque erosion. This is the definition for ACS. And in a year, around 1.57 million admissions are due to ACS. Out of that, the unstable angina and the non-STEMI constitutes around 1.24 million admissions. The acute ST elevation MI constitutes around 0.3 million. When we analyze the cardiac deaths in a year, the ACS, death due to ACS constitutes almost around 50%. So 50% of the death is due to ACS when you see the cardiac cause for the death. So such an important entity, and there should be a proper program or a proper strategy for the treatment of this ACS. So based on the ECG, we can divide this ACS into where there is an ST elevation or where there is no ST elevation. ST elevation will become an STEMI, ST elevation MI. In a patient with no ST elevation, and there are some ECG changes, then if the cardiac markers are positive, that is raised, then it becomes a non-ST elevation MI. Or if the cardiac markers are negative, it becomes an unstable angina. So the treatment strategy depends on whether it's an ST elevation MI or a non-ST elevation MI or an unstable angina. So the ECG is very important. Pathophysiologically, if you see the unstable angina means there is a non-occlusive thrombus in the coronary artery, which has not produced any myocardial damage. There is an occlusion, it's not fully complete, blood flow is reduced, but it is not producing any myocardial damage. So the cardiac markers are not elevated. In STEMI, there is again a non-occlusive thrombus, but it has produced some myocardial damage. So the cardiac markers, the proteins are raised in the blood. There can be ST depression or T wave inversions. In STEMI, there is an occlusive thrombus. The coronary artery, that particular coronary artery is totally occluded. There is no blood flow in the coronary artery. So there will be elevated cardiac enzyme, the symptoms will be more severe. So to diagnose an acute MI, ACS, we should have at least 2 out of these 3 things. One is the history suggestive of an angina or an anginal equivalent, or there should be an ECG change, or there should be a rise and fall of cardiac markers. Nowadays they have included echo also in this. When there is a region wall motion abnormality in the echo, that also can be taken up as a point towards this. So 2 out of the 3 should be there to diagnose a acute myocardial infarction according to the World Health Organization. So this is acute ST elevation MI. We know there is elevation in lead 1, AVL, V2 to V6, and this is non-ST elevation MI where there is significant ST depression and T inversions in multiple leads. So time is a very critical element in the care for acute coronary syndrome. The time to pre-perfusion following an ST elevation is a very, very, very important topic, and we will be discussing about that. Time to cath following thrombolysis, when we should do catheterization, angiogram after thrombolysis, that timing is also very important. Timing of a non-culprit artery in a primary PCI. One person may be having multiple coronary artery disease, may be having 2-3 blocks. After opening up that particular infarct-related artery, when we should plan for the further procedures. And time to angiogram for a non-ST elevation MI, when we should do angiogram after a non-ST elevation MI. This is all because there is a subepicardial zone of ischemia, which is viable, and it is available for pharmacological or surgical salvage. And it, as the time increases, say at around 40 minutes, it's a very small area of infarct, and most of this area is viable. After 3 hours, the infarct size increases, there is some viable area, and after 24 hours, it has become a permanent infarct. So the timing is very important. So when you analyze this, the benefit per 1,000 patients is highest in the initial 1 or 2 hours. It's very high, 80% benefit is there if you treat the patient within 1 hour. After 1 or 2 hours, the benefit drastically falls down, and it becomes almost 0 or 10% at the end of 15 hours or 18 hours. So up to 1 hour, 1 to 2 hours, 40 lives can be saved per 1,000 patients. So similarly, the onset to presentation to primary angioplasty, if it can be done within 2 hours, the mortality, 6-month mortality is 5.1%. If it's done after 4 hours, the mortality is more, going up to 6.7%. So the mortality increases as there is a delay in the treatment. Similarly, for fibrinolysis, thrombolysis, if it is done less than 2 hours, the mortality is 5.4%. If it is done more than 4 hours after the chest pain onset, it becomes 15% almost 3 times the increase in the mortality if there is a delay in the institution of fibrinolysis. But if you can see an interesting point, less than 2 hours, the mortality is almost same, 5.1% and 5.4%. So thrombolysis is also a very good option if the patient presents very early. Less than 2 hours, it's almost equal. If there is system delay, there is first medical contact to starting of the treatment. As there is a delay in the starting of the treatment, the mortality increases. So we should start the treatment as early as possible. This is what is called the golden hour. The first hour, there is only very little heart muscle damage. This is called the golden hour for the patient to present to the hospital. They should be present in the hospital within 1 hour after the onset of symptom. 1 to 2 hours, there is minor heart muscle damage, but it's mostly salvageable. So this is the golden hour for reperfusion. First 2 hours is the golden hour for reperfusion. 2 to 4 hours, there is some heart muscle damage with moderate heart muscle salvage. We can salvage, but there will be some permanent damage also. 4 to 6 hours, there's a significant heart muscle damage, and we can salvage only minor heart muscle. After 6 to 12 hours, it becomes permanent, then the benefit is much less. After 12 hours, it's not routinely recommended reperfusion. So the reperfusion can be primary PCI or fibrinolytic. Previously there used to be a lot of debate about whether thrombolysis is better than primary PTCA, all the thing. Now it's all settled. Primary PTCA is the best compared to the thrombolysis, because fibrinolysis with the best of the best thrombolysis, we can achieve only around 60% reperfusion rate. With primary PTCA, it's around 96 to 97%. So primary PTCA is always better, but if there is no facility, especially if the patient presents within 1 or 2 hours, thrombolysis is a safer mode also. This is what we should try to see. As when the patient develops symptoms, he should contact emergency medical staff, and when they arrive and see the patient, they should shift him as early as possible. And in Western countries and all, they have a system called pre-hospital thrombolysis. In the ambulance itself, they will thrombolize. They will take an ECG, and if they see an ST elevation MI in the ECG, they will start thrombolysis in the ambulance itself. Pre-hospital thrombolysis is very much advocated in all the Western countries, which is probably not possible, not very much in our country, but if you give proper training to the emergency people, they can do all that thing. One small question I can ask you. Do you know which is the largest cardiac center in India? Not Meenakshi Mission. Yes, that's where I studied. Jayadeva Institute of Cardiology from Bangalore. Okay. What I am trying to say is 20 years back, it was a 7-story building only for cardiology. All 7-story. Cardiology and cardiac surgery. Okay. 500 beds. This is 20 years back. Now it is tremendously increased. When I joined, it was only 3 PGs, DM PGs. Now 21 PG per year. So for a course, for a classroom, 60 students will be sitting. You can imagine DM cardiology, 60 students sitting. Such a large institute. There used to be a system, ambulance duty. Okay, all the PGs will be on ambulance duty on that particular admission day. One PG, all the day, every day. So whenever there is a call from a house, ambulance will go, PG will go in the ambulance. They will see, they will take an ECG. If it is ST elevation MI, they will thrombolize in the ambulance itself. It was done when I was studying there. Now I don't know much, but it is possible. It is possible. So pre-hospital thrombolysis saves lot of time. You can save lot of lives if you do this pre-hospital fibrinolytic. Suppose if it is not possible and patient is transferred to a hospital. If the hospital does not have PCI facility, PTCA facility, then you should be thrombolized there itself if it is, there is no major contraindication. And the door to needle time should be less than 30 minutes. This is the golden hour, golden time. Door to needle time should be less than 30 minutes. Suppose the patient has reached a place, hospital, where there is PTCA is possible, then he should be taken up to the cath lab as early as possible, and the door to balloon time should be less than 90 minutes. Okay, so the door to needle time should be less than 30 minutes, door to balloon time should be less than 90 minutes. So the total ischemic time from onset of symptom to the starting of treatment, either thrombolysis or PCI, should be less than 120 minutes. That is the ideal situation. That is what we should try to achieve. So the golden hour for thrombolysis is less than 1 or 2 hours is the golden hour, and we should try to start the thrombolysis as early as possible, at least less than 30 minutes after the patient has come to the hospital. For PTCA, it is 90 minutes. In our hospital, Meenakshi Mission, we have a dedicated cardiology team, 24/7, always. And the people will be sleeping in the cath lab. And we are very famous for this primary angioplasty in Tamil Nadu itself. With whole Tamil Nadu, we are the people who do highest number of primary angioplasty. So the primary angioplasty should be done within 90 minutes. Non-PCI places where there is only thrombolysis available, they should get transferred to the place where there is primary PTCA is available. So it's a class 1 recommendation, that is no doubt at all. PTCA should be done in a patient in a hospital where there is availability of PTCA, and it should be done within 90 minutes of the first medical contact. Suppose the patient has reached a hospital without PTCA, he should be thrombolized within 90 minutes. Suppose the patient cannot, this hospital does not have a PCA capability, he should be transferred, and he cannot be transferred to a PTCA center within 90 minutes. Say it's Kanyakumari, there is only thrombolysis. He cannot come to Madurai within 90 minutes. So what should be done? He should be thrombolized there. If there is a delay for more than 90 minutes, they should not be transferred from Kanyakumari to Madurai without thrombolysis. That is the point I want to emphasize. If there is thrombolysis available and PTCA is not available, if you are shifting to a place where there is PTCA available, if that delay in transfer is more than 90 minutes, don't shift him immediately, give thrombolysis and then shift. That's the point I want to emphasize. Okay. Fibrinolysis is not always successful, because as I told you, the best of the best thrombolytic, that is the tenecteplase, the reperfusion rate is around 60 to 65% only. So around 30 to 40% it is failed thrombolysis. So when there is a clinical suspicion of failed thrombolysis, that is inadequate ST segment resolution. And again, this point is very important. Many of you may be little confused about this. 90 minutes after initiation of the thrombolysis, not at the end of the thrombolysis. That's what I want to say. You start at 10 o'clock in the morning, 11:30 you should analyze. Not after finishing the thrombolysis, another 1.5 hours, no. It's not like that. Initiation of the thrombolysis, 90 minutes after initiation, you should analyze whether there is adequate, less than 50% ST segment resolution in the ECG. The continuance of the chest pain, how much 50% reduction in chest pain, that's also one criteria they say, but it is very, subjective, because many times you would have given some medicines to reduce the pain, some sorbitrate, some morphine, some fentanyl, okay. The patient may not be in a position to tell you how much it has reduced chest pain. So it is possible to evaluate if the patient is fully conscious, but sometimes it may be faulty also. So ECG evaluation is very important. ST segment resolution less than 50%, 90 minutes after initiation of the thrombolysis. If it is like that, then it's a failed thrombolysis. There we should try to do rescue PTCA, which can reduce the mortality, which can reduce reinfarction rate, which can reduce the cardiac failure rates also, with a little bit increase in the hemorrhage and hemorrhagic stroke. So this is one such patient. This is the right coronary artery. You see it is, play again. This is the right coronary artery, which is totally occluded. You can see it is fully blocked here. And play this. Yes. This is after the stenting, how beautifully the blood flow has been restored, and there is no stenosis here at all, fully normal after PTCA. This is again, this is the left circumflex artery, this hanging structure, and that upper one is the left anterior descending artery. And this patient had severe mitral regurgitation also, because left circumflex supplies the mitral valve. So because it is totally occluded, the mitral valve was not functioning properly, there was severe MR, patient was in failure, and after the primary PTCA, the mitral regurgitation reduced, and play this one. Yeah, you can see such a long, big coronary artery, which was totally blocked here. Okay, this is possible only with primary PTCA. This is the left anterior descending artery, this long one. Play this. See, there is a tight stenosis here. See the narrowing there? Okay, this was an anterior wall MI after thrombolysis. Okay, patient had received thrombolysis. Play this. Received thrombolysis. Thrombolysis has worked. It has opened up the artery, but you can see there is a residual tight stenosis in the left anterior descending artery. Play this. This one. See, there is a tight narrowing there, and see after the stenting. Next. See how beautifully it is open. See, the heart is pumping nicely. So it is possible with the primary PTCA, and it should be done within 90 minutes after the onset of after the patient has arrived at the hospital door. Okay. What about non-ST elevation MI? When do you do angiogram for them? Okay. There are many studies, and apart from this one study, almost all the studies have shown that invasive strategy is better than conservative strategy. That means what? As early as possible, especially in high-risk patients, they are diabetic, elderly people. If the cardiac markers are elevated, if there is echo evidence of regional wall motion abnormalities, then we should take them as early as possible. So even in non-ST elevation MI, we should start angiogram as early as possible. When do you do angiogram? After a thrombolysis. When do you want to shift to the patient? Next day, or after 2 days, after 4 days? That question will be there in everybody's mind. See, so many trials, SIAM 3, transfer AMI, capital AMI. Look at the time from fibrinolytic to PCI. 3.5 hours, 16.7, 1.6, 4.9. Meaning what? We should do PTCA or at least angiogram after every thrombolysis on the same day itself. It should be done on the same day. So less than 24 hours is the time which is given in the recommendations. We should do thrombolysis, stabilize the patient for few more hours, shift him as early as possible to a place where there is PTCA, and the PTCA should be done within 24 hours. Then only the benefit will be there. Next day or after 2-3 days, the benefit will be very much reduced. Okay, so after thrombolysis, angiogram should be done, and if possible, PTCA should be done on the same day itself. Okay, this is all cardiology. When to do the other vessel PTCA and all, whatever it is, what they have told is before discharge, whether the patient is symptomatic or not, the other vessels also should be treated. If there is an LAD occlusion and there is a right coronary artery occlusion, if the LAD is the cause for the MI, do the primary PTCA to the LAD. Don't do, the point is, we should not touch the other vessels on the same time. Suppose the LAD is the cause for acute MI, do only the LAD. He may be having another 3-4 blocks. Before discharge, you take him up again and do the other vessels also. But that first time, primary PTCA should be only one vessel. That is the point. Okay. So, reperfusion is the most important way to save lives in acute MI. Faster reperfusion saves more lives. Early cath and PCI results are better in high-risk STEMI or non-STEMI. And they say time is brain. I'll say time is muscle, cardiac muscle. You do treatment earlier, you will save lot of muscle. Okay, the golden hour for the presentation is 1 hour. Door to needle time is 30 minutes for thrombolysis, Door to balloon time is 90 minutes. At the end, I'll say, time is muscle, yes. Time is money. Okay. Not this money, sir. Money, time. So I'll finish my talk. Thank you.
Thank you, Dr. Sampath. I would like you to tell them that in a primary setup, when they are not able to reach within this 30 minutes or 90 minutes, what best they can do for the patient who has got a positive ECG.
Yes. So, you know it is a cardiac pain. You should evaluate carefully because non-cardiac pains also can mimic like an angina. You should know when you should call this angina, when it is non-cardiac. ECG may be having some here and there some T inversions. Okay, but patient should present with angina or anginal equivalent, and ECG is like an IHD. If it is an ST elevation MI, primary physicians, if the patient has presented before 6 hours or at least within 12 hours window period, earlier it is better, at least up to 6 hours to 12 hours. If the patient cannot be shifted to a primary PTCA center, patient should be thrombolized there itself. Apart from other treatments, aspirin, clopidogrel, atorvastatin, if he is breathless, little bit Lasix, all that thing, sarbitrate, BPSI, all that medical treatment is different. Suppose the patient cannot be transferred to a place where there is PTCA and he has come within 12 hours, he should be thrombolized. Okay. And the thrombolysis, depending on the money, yes, but streptokinase is fairly okay, but if the patient can afford, I'll suggest tenecteplase. Okay. Among the thrombolytics. But if he can, yes. There is lot of difference. Streptokinase, the reperfusion rate is around 35 to 40% only. That is 60 to 65%. It's quite a cost. This is only 4,000-5,000, that is 50,000. That is there. But if he can afford, okay, thrombolize, stabilize him, and if possible, on the same day, shift him to Meenakshi Mission Hospital. Okay. See, patient has come, it is an IHD or IHD, MI, ST elevation or non-ST elevation, maybe whatever it is. You give aspirin. Okay. Aspirin 300 milligrams. Okay. Apart from that, the other antiplatelets. Okay, you have clopidogrel, you have what is called it prasugrel, and there is ticagrelor, Brilinta. Okay. Clopidogrel, again 300 milligram, you can give 600 milligram also. Okay. Prasugrel you can give, and ticagrelor you can give. Among these two, okay, clopidogrel is universal. You can give to any patient, IHD patients. Among prasugrel and ticagrelor, prasugrel should not be given in emergency room. Okay, should not be given in emergency room or in a primary facility. Okay, prasugrel. It is given only after angiogram. That is the point you should remember. If the patient is going for an intervention, means PTCA or CABG, PTCA especially, then only prasugrel should be given. Medically treated patients, prasugrel should not be given. That's why you don't give it in the emergency room, because we don't know what is the coronary artery disease there. We don't know what he is going to do after the angiogram. He may opt for a medical treatment. He may say that I can't afford. He may say that it is too difficult to treat. Blocks may be too much. So we may say that go for medical treatment. Okay. So prasugrel should not be given before angiogram. After the angiogram, if the patient is going for an intervention only, prasugrel should be given. Ticagrelor, that is Brilinta, what is commonly available. Ticagrelor is again an universal drug. It can be given in the medical, casualty. It can be given in a primary facility where there is only medical treatment. It can be given. It is better than clopidogrel, but little bit risk of bleeding will be there, more risk. Aspirin, everybody. Clopidogrel, it can be given to everybody along with aspirin. If you are giving clopidogrel, don't give ticagrelor. Both are almost same only. Aspirin plus one other drug. Okay. Aspirin 300 milligram, clopidogrel 300 or 60 milligram, ticagrelor 90 milligram. This should be the treatment in casualty or an emergency, or a primary. Prasugrel only after the angiogram. Statin, yes, immediately. No, immediately when you see the patient diagnosed IHD, acute MI, give him there itself. So it's something like a loading dose like statin also. Sorbitrate if the patient is having pain. Okay. If the BP is all right. If the patient is having failure, breathlessness, and BP is good, 130, 140, you can give a sorbitrate. Around 100, 110, maybe little dangerous. My teacher used to ask me, okay, in the rounds, patient has complaint of chest pain. You are given sublingual sorbitrate. Okay. Patient has developed hypotension. What will you do? He'll ask. We'll say start dopamine, start some saline, give some atropine, all that thing. You will say first ask the patient to spit the tablet, man. What are you doing? Okay. So sorbitrate, yes, in acute situations, if there is pain, if there is some breathlessness, you can give, but if BP should be monitored. Yes.
If there are no more questions, I think we can go ahead with the next topic. Further discussions can be had with the speaker personally. Please, we are running short of time.
Thank you, sir.
I would like to request Dr. Rajkumar Ramasamy sir to honor the speaker and the chairpersons now. I also request Dr. Safir to be honored by Dr. Rajkumar Ramasamy sir. Thank you, sir. Now moving on to the next session. Thyroid disorders can range from a small harmless goiter that needs no treatment to a life-threatening cancer. Most of these problems can be managed well if properly diagnosed well and treated. So the topic for this session is thyroid disorder as an overview.
Chairpersons for this session are Dr. Manoj, Consultant and HOD, Department of Internal Medicine, Vadamalayan Hospital, Madurai. Dr. Ramya R. and Dr. Pranita. She did her MBBS from Annamalai University, DNB Family Medicine at MMHRC, Madurai. She has been examiner of DNB practical exams. Now currently working as a senior consultant in Department of General Medicine at Meenakshi Mission Hospital and Research Center, Madurai.
The speaker for the section is Dr. Anand Kumar Annamalai. He is an API gold medalist in MD from Madurai Medical College, MRCP UK in Internal Medicine and Endocrinology, trained in endocrinology from the University of Cambridge, Chairman of Institutional Committee of Stem Cell Research, PG Institute of Ophthalmology, Aravind Hospital, Madurai. He has got Specialist Register Award, Best Poster Award, Outstanding Doctor Award of British Endocrine Society. Currently, he is consultant endocrinologist at Ashwin Specialty Hospital, Nithila Hospital, MMHRC and Vadamalayan Hospital. Over to the chairpersons.
Welcome, sir, in your busy schedule. Sir has actually gone for an IMA meeting at 3 o'clock, finished at 3 o'clock, and ran here to get get us into a knowledgeable session, sir. Thank you so much for coming, sir.
Thank you very much, ma'am, and thank you very much for the kind introduction. So, the topic which I've been given is thyroid disorders and an overview. And what I've done today is I've listed some clinical scenarios to actually, try to make things easy, because thyroid, in terms of testing now, is widely done, and I think everyone needs to understand and know what to do. So I'm going to kickstart with some physiology to just make you understand why, and how to interpret these tests. So the thyroid hormone coming from the thyroid gland has to feed back to two particular areas. One is the hypothalamus and the other one is the pituitary. So this is important because that regulates the thyroid hormone, and this is negatively basically regulated. From there, thyroid hormone goes on to the blood, and it's tightly bound. In fact, 99% is very tightly bound in the plasma with proteins. And there's only a very small percentage of like 0.5 or 0.3, which is actually freely available to go into each cell. Now, once it goes into each cell, now almost every cell in the body requires thyroid hormone. And that's the reason why when you have thyroid disorders, you get myriad of symptoms. You get symptoms in the brain, the muscle, the bone, the liver, heart, name it, you basically get it. So the thyroid hormone acts on the receptor, which is inside the cell in the nucleus. And basically, you have the conversion of T4 to T3 by the deiodinase, or the T3 enters the cell straight away through the MCT8 pathway. And this is important to understand, because if you're going to interpret tests, you would need to know this pathway. And if you know this pathway well, it becomes very simple. So when you interpret tests, so when you say hypothyroidism, you mean thyroid is low, so meaning that T3 and T4 is low. When you say primary hypothyroidism, if you remember the feedback loop, if the T3 and T4 is low, this would feed back to the pituitary and the hypothalamus, and that would increase the TSH. So this would have a low T3, low T4, and a high TSH. Now, contrarily, if you have primary hyperthyroidism, remember primary meaning that is where the primary thyroid is the problem. The T3 and the TSH are high, and the TSH would suppress. Now, if you have number 2 and number 4, I'd like you to concentrate on number 2, which is secondary hypothyroidism. Here, as it says, it's hypothyroid, meaning that the T3 and T4 are low. And what you would expect is this would feed back and the TSH should actually go high. Now, instead of that, if you have an inappropriately normal TSH or an inappropriately low TSH, that is abnormal, and that is secondary hypothyroid. When you say secondary, the problem is not in the thyroid but elsewhere. And secondary, as I said, it's going to be in the pituitary or the hypothalamus area. And similarly, secondary hyper, where you have the high T3 and T4, you would expect the TSH to suppress, but the TSH doesn't suppress, and actually the TSH is inappropriately normal or basically inappropriately high. So this is important to understand. We'll move ahead with the case. This is a 42-year-old lady who actually comes in with irritability, mood instability, depression, all features consistent with hypothyroidism. Now, if you look at her clinically, there's not much to add apart from a heart rate of 72 and a temperature which is a little bit low. Now, this particular situation, I've marked the abnormal tests in red. So as you can see, thyroid, so low thyroid, hypothyroid. You have the T4, which is low. So you would expect the TSH should rise. And you find that the TSH is appropriately rising. So the TSH is greater than 150. So this is primary hypothyroidism, and this is the most common disorder that everyone will face. This is as high as 15% prevalence in India. And this is both in urban and also rural settings. It is pretty high. It is even higher than actually diabetes. So the common reason for this is Hashimoto's or autoimmune thyroiditis. And this is primary hypothyroidism. And you rarely get this kind of a symptom, but you sometimes get this walking through our doors. So endocrinologists, we get referrals, but sometimes we get people walking through this without them knowing that they have primary hypothyroidism. So here, this person was commenced on thyroid hormone treatment. I'll talk a little bit about how we go about treatment. The symptoms improved in 2 months, and this was her sequentially. As you can see, this was TSH greater than 150, TSH 5.3, and TSH 1.2. You can see the dramatic improvement in terms of the facial features, and this is at presentation, 6 weeks, and at 4 months. So this is important to understand that you need to normalize the TSH very quickly for an appropriate result in terms of treatment of thyroid dysfunction. So if you have this pattern of someone with a low T3, low T4, and a high TSH, or a low free T4, low free T3 with a high TSH, this is primary hypothyroidism. And this is what majority of people will encounter. And this is important to understand and identify. There are lots of other reasons why you could have this, but it's important to understand common things are common. Now, why are we looking at TSH? So if you look at one marker, if you were to be cost effective and say, I'd like to look at one, what would you look at? You would look at TSH. Now, why would you look at TSH? So if you look at this, the TSH is the first thing which rises sharply and abruptly. All the others take some time. So if you were to pick up someone with hypothyroidism early, you would find that their T3 and T4 are normal and the TSH is high. So you may pick it up early. And that's the reason, because lots of times, people have master health checks, they just get tests left, right, and center. They come in with a high TSH and a normal T3, T4. And we get phone calls saying, so is this normal? Is this something which we need to treat? Now, this is important to understand, that this is how this basically, it happens. And the decline of T4 and T3 basically is slower, and it's variable. So this is very important to understand. The other thing is, how would you treat hypothyroidism? Now, this is important. So this is actually an art. I mean, there's a science to it, but always, in medicine, there is an art towards how you treat things. So you would need to treat all overt primary or secondary hypothyroid patients. This is very, very important. It is important you need to treat. You would not treat if hypothyroidism is transient, or if it's in relation to thyroiditis or subacute thyroiditis. So it is important to differentiate these two. And if it is drug-induced, like amiodarone or any other drugs which can interfere with the thyroid hormone systems, it is important to wait and watch before you continue treatment. So as far as the guidelines are concerned, what are the targets? You would aim to treat to the TSH. So if you look at the first case we were talking about, you would titrate to make sure that the TSH runs within range. It can range from 0.5 to 3.5 to 4. And this is important. The other important aspect is the TSH varies depending on age. Now you have different people, people are different. So the TSH concentrations in older people are different. So at 7.5, with someone who's super elderly, with 70, is actually normal. That is physiological. You would not need to treat that particular individual because their TSH is high. So what about this TSHs between 5 to 10? TSH of greater than 10, yes, you would treat if they are primary hypothyroid. What about the 5 to 10s? Now the 5 to 10s, you could differentiate between 5 to 7 and 7 to 10. Now if you have a younger person, when you're talking about a younger person of less than 55 years of age, who is symptomatic, who has a 5 to 7 or 7 to 10, you would treat. If you have a person who has a thyroid peroxidase antibody or a thyroid antibody positivity with this in-between TSHs, you would consider treatment. So this is important to understand that why you would do that, because as I said earlier, the TSH is the first thing to rise. So are they at risk for progressive loss of T4 and T3 function is the question. So the goals of therapy, as I said, it's always symptoms. People have a myriad of symptoms. Whether you're able to tackle everything is secondary, but you would tackle most of them. You would normalize the TSH. If there is a thyroid swelling, you would need to normalize it. And you would need to avoid excess treatment, because excess treatment would lead to cardiac issues and also loss of bone. And these are important. Now, what are the factors which determine TSH and their targets? As I mentioned, age is an important aspect. Weight is an important aspect. The cause for the hypothyroidism and the degree of TSH elevation and the clinical context, as in who is in front of you. Is it a pregnant lady? Is it a youngster? Is it a child? Or basically, is it someone in the intensive care? All these are basically important. The cardiac disease status, again, would determine how you would give thyroid hormone. Now, TSH goals clearly have to be individualized as per the clinical situation. So the dosing principle, age, as I said, plays a role. Why? Because basically children are supposed to clear thyroid hormone very fast, and the elderly clear it slowly. So the dosing requirement is pretty different. For an elderly person, you have a lower requirement. For a young person, and like let's say for a pediatric population, the dose is higher. And this is in relation to physiology. The other important aspect is in pregnancy, there is an increased requirement of at least 25 to 30% of dose. As far as dosage is concerned, you could base it on body weight. So when you start with a dose of 1.6 to 1.8 micrograms per kilogram body weight, as from the previous speakers, everyone was saying time is muscle, time is brain, but I would say thyroid is time. Because if you don't give it in time, you miss the boat. So we are king. Everything starts with thyroid. So the dose requirement basically is particularly important, and it's the way you give it. You give it on an empty stomach. You ensure that there is a difference between when you take it and you take food, because your thyroid hormone starts getting absorbed right from the buccal cavity all the way down into the intestine. So you would need to wait for it to have its action. Any interference, South Indian coffee, strongest interference. Filter coffee, strongest interference. So it will affect it. And that's the problem. Most of us basically, the people who treat thyroid, if you ask people, they say, oh, I take coffee 45 minutes, 30 minutes, 50 minutes. 1 hour is a standard requirement. So what's the best approach in terms of thyroid hormone initiation and adjustment? As I said, 1.6 to 1.8 is the standard dose. However, if you find someone who has an atrophic thyroid or basically who has a progressive deterioration in terms of the thyroid gland, the dose requirement is going to be very high. So 1.6 to 1.8, yes. If you have someone who's in the subclinical hypothyroidism range, where would you start? You can start at the ballpark figure of 25 to 50. That's an easy way to start. It's important to make sure in this particular situation you start slow, go slow, and actually go appropriately. If you make a change, it is important you check thyroid hormone tests in 6 to 8 weeks. For elderly, super elderly, and cardiac patients, be cautious. You're okay to go to 12.5, 25, or 37.5, or even lower. And it's important to do it very cautiously. Because if you overdo the thyroid hormone replacement, you could precipitate a myocardial infarction when someone who is super elderly or someone who has multiple vascular risk factors. So remember, that has to be done very cautiously. So as I mentioned, start low and go slow. Timing, as I mentioned, thyroid is time. It's important. And if you have shift workers, a lot of times, the question is, can I take my medicine at bedtime? Yes, you can if you're a shift worker, if you basically, going to work late in the night and then, coming back in the morning, and your day is different and your night is different, change it accordingly. Or the other thing we tell them is, at least maintain 2 hours since the last meal before you take your thyroid hormone. Someone who's fasting and someone who wants to take it differently, this is important to understand. So there is a lot of interaction with other medications, and that needs to be understood. And you could adjust thyroid hormone based on what your levels are. If your levels are greater than 5, you would need to increase it still higher. So if your levels are less than 0.5, you would need to decrease. And if you're between 0.5 to 5, you're actually okay. And then you basically keep repeating thyroid hormone tests. So you measure the TSH if you make a change. You measure the TSH in 4 to 6 weeks, and you titrate based on 12 to 25 or higher, depending on where your T4 and the T3 levels are. So in general, your requirement is not going to go greater than 2 micrograms per kilogram in an adult. And if you're requiring this, that would mean that person is fooling you, or that person is not taking it correctly. So it is important to keep that in mind. So you need to keep checking, find out if their medicines are okay, if they're taking it properly, is there any interference within their pill box? There's a reason why it comes in a bottle, so this is important. So why is it checked after 6 weeks? There's a 1-week half-life for T4, and you need to wait at least 6 half-lives before you actually check, and that's why we do it once every 6 to 8 weeks. And you could do a free T4 in between to kind of assess if you're doing the right thing. You've increased the thyroid dose, you want to know whether it's actually doing well, you've given the right thing, that's basically how you look at it in terms of maintenance. So as I mentioned, there are lots of things which actually affect thyroid dosing. Pregnancy is a big risk factor in terms of increased dose. If you're giving someone estrogen therapy, oral contraceptive pills, the requirement is going to go high. If there is a progression of the Hashimoto's in terms of the gland or in terms of how they are, that basically can increase it. Weight is an important factor. 10% or greater weight increase means that the thyroid hormone requirement is going to go high. You have other issues like nephrotic syndrome, where the dose requirement is going to go high. Drugs, as I mentioned, again, would have an interaction. So if you look at different patterns, so if you have a pattern where basically the TSH is high, or if you basically have a free T4 which is high. So this is someone who's just come into clinic just 10 days ago and wants to impress the doctor and is gulping 2 tablets or 3 tablets every day to make sure that they normalize. But they don't know the science of the 6 half-lives, so it's not going to normalize. You'll get a very high free T4, but you'll have the TSH which is still high. So this is someone who's actually trying to fool you. Now, if someone has inadequate thyroxine, you would find that the free T4 is either in the normal or the lower normal range with a slightly increased TSH. And this person, yes, you would need to increase. So you need to identify patterns. So this brings me to case number 2. This is a 32-year-old female who had primary hypothyroidism, is on thyroid 100 mics per day. And basically, investigation showed that a free T4 was normal and the TSH is high. So the question here, what would you do? So you have someone who has a normal free T4 and a TSH is high, and you also find that the prolactin is elevated. So this is someone clearly, yes, primary hypothyroidism, also has hyperprolactinemia. Someone did an MRI and the referral was sent across to the endocrinologist, and the question was, this is primary hypothyroidism, pituitary enlargement, can we refer for pituitary surgery? And this was a primary care physician asking this question. The answer is no, this is actually not a pituitary adenoma. The prolactin rise is physiological. You correct the thyroid hormone, this would normalize. So what did we do? We actually suggested strict compliance, increase the thyroxine dose, And this was the sequential MRI pictures. So no surgeon had gone here. This was all medications. So this was presentation with basically correction of TSH from 80 to 6.8 to 1.5. As you can see, this so-called pituitary lesion has disappeared with thyroid hormone corrections. So this is poor compliance with levothyroxine therapy. This results in lactotroph hyperplasia with hyperprolactinemia. The thyrotroph hyperplasia, as you remember the first slide I said, the T4 is low, you feed back to the pituitary tries to produce more TSH. As the TSH starts getting bigger, the pituitary enlarges, and this is physiological. You correct it down here, the pituitary starts shrinking. So this is what you would have. So you would be bad to send this person to surgery because you would normalize this with just simple correction of thyroid hormone. So this was 125, and as you can see sequentially, we brought this person back to 100. So this was non-compliance, and that is a problem. Non-compliance is a big issue, so it's important to understand this. So if you find this pattern of free T4, free T3 being normalish, and a TSH which is high, remember this could be, in someone who's being treated, this could be someone who is actually having a poor compliance with thyroid hormone. And I just spoke to you about the thyrotroph hyperplasia and the lactotroph hyperplasia. So as far as children are concerned, they clear the thyroid hormone very fast, and that's why their requirement is higher. For an adult, the dose is something like, as I said, 1.6 to 1.8, but for a child, your requirement is 16 mics per kilogram, a huge walloping dose. So as far as pregnancy is concerned, this is a snapshot of what you should be doing. We can probably discuss at the end. I mean, it's by itself is a topic, but in summary, if you find someone of TSH greater than 4, you would consider treatment in pregnancy. Anything less is probably not ideal to treat. You would need to discuss with the endocrinologist. So case number 3, this is a 47-year-old woman who presents with marked tiredness and basically is hypothyroid because of radioactive therapy for hyperthyroidism, and is on thyroxine 275 micrograms once daily. And with this, basically, she still has persistent clinical features of hypothyroidism. And you can see her sequential thyroid hormone, thyroid tests, which basically show, a variability. So initially it followed a pattern, and then later she's on like 400 micrograms per day. So remember I said 2 mics per kilogram, body weight or greater, be careful. Are they really taking it? So this is 400 micrograms per day, and you still have no sign of this getting better. She swears that she's taking it every day. She's gone from pillar to post from different units across different hospitals, but still, everyone says it's non-compliance or we don't know what it is it malabsorption? So when you have this kind of a situation, as I mentioned, you consider something called an assay interference. Next thing you consider is something related to thyroid hormone malabsorption. As I mentioned, filter coffee and South Indian coffee has a huge role. The other important aspect is drugs. Iron basically has a big importance. Antacids have a big importance. PPIs decrease hydrochloric acid, and when you have decreased hydrochloric acid, it decreases the absorption of thyroid hormone. These are important things to understand. If you accelerate the metabolism with drugs like anti-tuberculous drugs like rifampicin, if you're on anti-epileptics like carbamazepine or phenytoin, that basically can also cause that. And if you have increasing binding capacity drugs like oral contraceptive pills, this would again increase the requirement of thyroid hormone, and that can affect it. We look at all of this, and then you think in terms of compliance, because we don't want to blame our patient about compliance, but you need to consider all these factors before we actually say so. I must say, in the years of practice, the malabsorption syndromes are really extremely rare as a cause of this kind of hyperthyroidism. So what did we do here? So we did something novel, and this is a test which you should not be doing in primary care. It must be done only in the hospital. So we give a walloping dose of 800 micrograms of levothyroxine, and this is a patient who basically goes very well. Remember I said free T4 you can check in between. You can see within a few hours you find that the free T4 increases. Now for our patient, this was flat, so this really didn't pick up at all. Now the beauty was, what can you do with this situation? And this is where, phone a friend and phone a senior always help. Experience helps. So I spoke to one of my senior colleagues in the United Kingdom, who's the giant expert in clinical endocrinology and thyroidology, and he advised something very simple. We don't have, thyroid liquid over here, but he suggested we could use thyroid liquid with 800 micrograms and use a chaser, meaning you ask her to drink and drink another glass of water. And look what happens here. It goes up. So what she was doing was the 800 micrograms, she kept it under her tongue and then she spit it out. So, she was fooling all of us. And with the water, she couldn't really fool anyone, so it went inside. So this is basically, important. never ever underestimate the ingenuity of the patients. I mean, she's been to almost all hospitals, basically, with no diagnosis made, and this simple thing actually did the trick to find out what basically it was. So non-compliance was an issue. So thyroxine dosing and adjustments depend on the clinical context, and the goals of therapy include both on clinical picture and biochemical picture. As I mentioned, the age, weight, etiology, all of these factors, pregnancy, cardiac status, have an important role in terms of deciding how you would treat thyroid hormone. A word about thyroid nodules and thyroid cancers. So if you were to screen people, and this is unfortunate because everyone gets an ultrasound of the neck nowadays, and if you actually look at ultrasound necks, 40% of people have a thyroid nodule. So that's a problem. These incidentalomas, the thyroid incidentalomas. And if you look at literature across the globe, the incidence of thyroid cancer is increasing across the globe, but the mortality is actually the same. So actually we're just overworking and we're actually looking at more of these, which we don't need to be looking at all. So I would suggest if you're able to feel it, do a neck scan. If you're not able to feel it, don't do a neck scan. So why? Majority still are benign. 80% are colloid nodules, 10% follicular adenomas, and only less than 1% are actually malignancies. So the risk of malignancies are more with males, extremes of age, and actually rapid growth, and previous head and neck irradiation, family history, all these are important. So what would you do? You would do a TSH. That's the simplest test. Because if you have a hyper-functioning nodule, so hyper-functioning would mean hyperthyroidism, the TSH would be low, the chances of malignancy are very, very low in this situation. An isotope scan can be useful, but it's not always going to be useful in terms of determining a thyroid malignancy. The most important thing is operator-dependent ultrasound scan of the thyroid, and that would decide on suspicious features of a thyroid nodule. And with that, you do a fine needle aspiration cytology. And these two important things are important. And if you were to look at markers, these are important markers. If you look at this particular aspect here, this microcalcification, this look at increased vascularity within the nodule, the indistinct margins, and the size of greater than 4 centimeters. All these are, warning markers to suggest that it's something which is important. So as I mentioned, not clinically palpable, don't do a scan, because you're going to find an incidental nodule, you're going to upset everyone, and you just won't know where to go. So detected on ultrasound, if it is less than 1 centimeter, just leave it. Greater than 1 centimeter, yes, you would need to do an FNAC under ultrasound guidance. The frequency of cancers across the world, including India, the commonest still remains is papillary, and the other ones are basically, less common. However, it still remains a job with the endocrinologist. It doesn't go to the oncologist, and that's a good thing because that means we can cure it. So this is the thyroid cancer distribution from India. So with this, another case, a 52-year-old male with a thyroid nodule with an 8-year history of left thyroid nodule gradually increasing in size. And this is interesting. So 2 FNAs were done, and these were benign. This person has no history of thyroid cancer. And these were the thyroid hormone tests. And again, as I mentioned, the radiology is very vital. The FNAC said it is normal. The ultrasound said 2.6 centimeters hypoechoic nodules. Now that is a warning sign. The taller than wider anteroposterior look of that nodule, that again is a warning sign. FNAC kept saying benign. The patient was refusing to go for surgery. We said, no, this doesn't look good. This is an atypical nodule. The total thyroidectomy was done. The histology was papillary thyroid cancer. So you can see the nuances here in terms of how to kind of detect this. So radiology, as I said, it depends on who's doing it, and you look at these features, and this is what's basically going to be important. So any palpable thyroid nodule and nodules detected in ultrasound which is greater than 1 centimeter in size, you evaluate. Otherwise, you don't. So this is someone with a 45-year-old female with hyperthyroidism. As you can see here, this is free T3 and free T4 are high with an appropriately low TSH. This is commonly because of Graves' disease, because of thyroid receptor antibody positivity. You can find that the TRAB is very high. They've had basically an uptake scan, and that uptake scan shows increased uptake on both sides of the thyroid gland. So the reason I'm mentioning this is it is important to measure this particular molecule, the thyroid receptor antibody, which is very, very important to determine the etiology of thyrotoxicosis. And this is best even without the nuclear medicine imaging. And this is very quick. So this particular individual was decided to treat with antithyroid for 2 years. So why is this important? So this is a particular situation where you could actually treat and actually cure. So you can go for remission with just oral medications alone. So a properly titrated antithyroid dose regime would help in 60 to 70% of remission if it's properly followed and done correctly. So the utility of thyroid receptor antibody will tell you whether it will work. So if your thyroid receptor antibody is pretty high, it may not work, it may take time, and then you can decide on possibility of surgery or the possibility of radioiodine if needed. But this is a utility tool. And this particular study actually says a 5-year follow-up looking at the effects of thyroid receptor antibody and the various modalities of therapy. If you look at the various modalities of therapy for thyrotoxicosis, in India, majority still prefer surgery. In Europe, the preference is medicine. And in America, the preference is actually radioiodine. So we are so divided in the world because no one knows which is right. But here, this particular trial tells us with the thyroid receptor antibody which works best. Now people are increasingly coming back to medications. Medications basically result in 60 to 70% improvement. Look at that 5-year window. It even beats surgery in terms of the resolution of thyroid receptor antibody in comparison to radioiodine, which means it still is there. And that's why we still think that medical therapy is very effective here. So someone with Graves' disease, it is important to consider antithyroid drugs for a period of at least 12 to 24 months. The chances of remission are dependent on lots of factors. One important factor is the measurement of thyroid receptor antibody. The other one is the size of the goiter. The other important aspects are the peak of the free T4. All these would determine whether they would respond to medical therapy. But as I said, if it's appropriately done and titrated, we would result in a remitting phase. So you could have different phases of how you could have this Graves' disease. You could have Graves' disease which is unremitting. Irrespective of therapy, it's always going to be there. So this is someone who you need to control and send them to surgery. You could have a cyclic pattern, a remitting and relapsing type, which can go up and down. Now, you could continue with medical therapy in this kind of a situation, but basically, eventually medicines may still work. Now, these two are the 20 to 30%. The vast majority are the early remission. So if you do this properly, you basically get this correctly and you actually go into remission. So it's important to understand that this is what you do. My last case for the day is someone with a TSH which is high and the free T4 and the free T3 which is normal. So this is the subclinical hypothyroidism which we're talking about. This is someone who's not on any thyroid medications. Now, would you treat this particular individual, a 32-year-old female? It depends on the situation. However, you find that the thyroid antibody is positive. To treat or not is going to be based on the TSH levels, as I said initially, and also on the thyroid peroxidase antibodies. And why would you base this on the thyroid peroxidase antibody? If you have TPO antibody positivity, the chance that every year they become overt hypothyroid is as high as 4 to 5%, meaning in a decade, at least half of these individuals will become overtly hypothyroid. So if you have this positive, it is important you consider that you actually, you could. Now, if it is less than 10 and they have a normal TPO and basically, they are otherwise okay without any goiter, the chance of them actually normalizing in the first 2 years of diagnosis is very high. And this is more so in children. Now, if children are obese, you find that there's a connection between insulin resistance and TSH. So if they get the weight down, the TSH will normalize. It's not the other way around where basically the TSH is high, so they're actually, putting on weight. They're basically increasing weight and that's reflecting on the TSH. So it's just physiology. Correct it and they're fine. So 18-year-old, so this is my last case, 18-year-old female who presents with primary gravita and excessive vomiting. So this is someone who has what looks like a hyperthyroidism picture, a high T3, high T4, and a suppressed TSH. Now what is this? So you would find this a lot in terms of results because pregnant ladies come with these results. So do we treat them? Are they hyperthyroid? The answer is no. This is gestational hyperthyroidism. This is because of the beta-HCG, which has a similar structure to the TSH. The beta-HCG stimulates basically the thyroid hormone because of the similarity. And as the beta-HCG peaks and comes down, it gets better. In our women, our Asian women, our Indian women, our women around Madurai, this is very common. So you find this going up and coming down. All you need to do is supportive care, supportive care, supportive care, and they will be fine. Don't go and treat them. So the antibodies here were normal. So this is someone with hyperemesis gravidarum with gestational hyperthyroidism. So with masterly inactivity, nothing much done with supportive care, people do pretty well. So to conclude, I've got 2 minutes to the clock. These were clinical vignettes of various facets of thyroid disorders for family practitioners. I hope I've made things easy and clear, and I'd like to summarize with what Dr. William Mayo always says. The glory of medicine is that it is constantly moving forward, and there is always more to learn. Thank you very much for the opportunity.
It was indeed a very mind-boggling session, sir. And is there any role of empirical thyroxine therapy apart from the TSH variations, hyperthyroidism?
You mean for obesity, ma'am, or just
Yes,
in general? So, yeah.
outside.
So-
Few
so-
patients come with those prescriptions for obesity.
Right. So this is across the globe, ma'am. So unfortunately, no. So if you give thyroid hormone medicines when they are normal, you actually precipitate hyperthyroidism. And when that happens, you actually, can stimulate the heart. You can stimulate forms of atrial fibrillation. You can stimulate osteoporosis. You can get more bone pain and body pain. So it's actually more detrimental. So we should do away with the habit of, when anyone's doing that, we should do away with it. We see a lot of alternate practitioners like Ayurveda and Siddha who actually, so-called, drugs to give obesity. And actually what they're doing is they're rolling the thyroid hormone medicines and giving it to them as obesity drugs. So you do their thyroid hormone function test, it's over the roof, and clearly you can see that they're actually taking these pills which actually have thyroid hormone medicine. But it's a good point. I think, we should not be giving it at all.
Can you tell us something about hashitoxicosis?
Oh, sorry, ma'am. Fine. Yeah, so hashitoxicosis is a very important thing to identify. And the reason why we are increasingly possibly going to identify this is because of the frequent tests we're doing. So if someone has autoimmune thyroiditis and they have a positive thyroid peroxidase antibody, they actually go through a phase of hashitoxicosis. And that hashitoxicosis can be very variable. Some people can last for a few days, some people can last for a few weeks. So what happens is the thyroid antibody stimulates the thyroid hormone thyroid gland, and the thyroid hormone is basically thrown out into the body. So you have features which are suggestive of hyperthyroidism. So people come saying, I'm feeling very jittery, I've got a lot of pain, I'm sweaty and all that. And they present like someone with hyperthyroidism. Now the most important thing there to consider is to do these antibodies. The way we differentiate it is do the thyroid peroxidase antibody. The thyroid peroxidase antibody in these situations would be sky high, and they would be thyroid receptor antibody negative. So these individuals, you just need to wait and watch, treat them symptomatically. If it's tachycardia they're concerned about, I would give them beta blockers. If it's pain they're concerned about, I'll just give them simple analgesia and wait. And then after 4 to 6 weeks, they would eventually become hypothyroid. Lots of times, as you say rightly, ma'am, we find people with that, they actually get, an anti-thyroid drug, and they come 2 months later with gross hypothyroidism, which is very, very low. So that's something to identify.
Steroids in them?
So there's no role for steroids for actually reducing the thyroid peroxidase antibodies. There's a role for selenium supplementation, which has some data to say that it's actually beneficial. Steroids specifically, in terms of one thing I didn't touch was I took that case off for lack of time, was someone with thyroid eye disease. So thyroid eye disease can occur. People generally think that thyroid eye disease can occur only with Graves' thyrotoxicosis. The answer is no. You could get someone with hypothyroid with actually thyroid-related orbitopathy. You could get someone with a completely normal thyroid with thyroid-related orbitopathy. Then why is it called thyroid-related orbitopathy? Because of the thyroid receptor antibody. The thyroid receptor antibody stimulates the orbital fibroblasts and it can cause that. And why am I talking about that? And that's kind of a situation you could give steroids to ameliorate the symptoms in terms of the orbital fibroblast expansion and the decrease in size, which will actually cause decrease in won't cause decrease in proptosis, but decrease in terms of the pain and the symptomatology related to the thyroid-related orbitopathy, like specifically diplopia.
Thank you, sir, for the talk. You mentioned about gestational hyperthyroidism, no need to treat it. When do you decide you have to treat?
It's a good question again. So gestational hyperthyroidism, when it becomes like, true hyperthyroidism is when we decide. So the case, as I mentioned, so as you can see there, one thing which I couldn't delve some time on was looking at the total T4 and the total T3. Although if you look at the total T4 and total T3, it looks high. Remember, in pregnancy, it is different. So the TBG effect, meaning the thyroid binding globulin, going back to my first slide, thyroid hormone binds to actually plasma proteins. The thyroid binding globulin increases in pregnancy. So as that increases, you would measure an increased amount of thyroid hormone normally. So the best way is your labs don't automatically give you a normative value for pregnancy. So you have to multiply it, the higher upper limit of normal, by 1.5. So for pregnancy, if they fall within that range, they're actually okay. So that means they're not actually truly hyperthyroid. They're just physiological. It's just going up. And because, as I said, our ladies are very sticky in terms of the beta-HCG, and actually, so there are like 3 sisters. The TSH is a glycoprotein hormone, the beta-HCG is a glycoprotein hormone, LH is a glycoprotein hormone, and TSH is a glycoprotein hormone. And all of these actually share similar structures. So all of them look similar and act similar. So if you have a lot of beta-HCG, it goes and does the job of what the thyroid should be doing. If you have a lot of FSH, sometimes it does that, and that is in pathological states. In pregnancy, if you have a very high FCG, or if you have like hyperemesis, if you have a twin pregnancy, it can go and stimulate the thyroid and actually push it up. So all you need to do is wait for that HCG to come down, and everything settles. In true hyperthyroidism, the pathogenesis is different. It is thyroid receptor antibodies which actually stimulate the thyroid per se, and there you would need to treat. Good question again. So, yeah, there's a lot of food fads in terms of hypothyroidism. As I mentioned, the commonest cause, even today in India, is actually autoimmune hypothyroidism, or basically Hashimoto's thyroiditis. There have been, there have been no studies looking at, which basically is beneficial in terms of long term. But the short answer is no. They can actually have anything. So the question is, a lot of times people come say, oh, can I eat cabbage? Can I eat nukkol saplama, katrika saplama, either saplama? So the Brassica family, vegetables are very good vegetables. They actually, have a lot of benefit in terms of inhibiting carcinogenesis. It has a benefit in terms of health and lifestyle roles. So I tell them, take it. It will do nothing. It will do nothing. Previous years, you had these goitrogens, which used to basically have, people used to have severe iodine deficiency, where you had large goiters, and that used to interfere with those substances in terms of thyroid hormone production. Nowadays, we are actually iodine replete. We have a lot of iodine floating around everywhere, so that will have no role at all. The soy, specifically for infants, may have some interferences, but not really in a big deal. So, and they must be really, taking it in a bulk amount if really it has to interfere. So as we said, thyroid is time.
Thank you, sir. Now I would like to request Dr. PKM, sir, to honor the speaker and the chairpersons.